Mhm.
Okay.
Respected faculty members, panelists, and delegates, good evening, one and all. Let's start the 10th session of the International Bi-Monthly Webinar Series, Learn from the Legends, organized by IAP NeoChap and NNF Kerala. Let me take this opportunity to welcome today's faculty, Professor Manuel Sánchez Luna, who is the Medical Director of Neonatology Division of Gregorio Marañón University Hospital, Madrid. He is a person who has dedicated his whole life for the research in neonatology field, and he is the president of Spanish National Society of Neonatology. I welcome you, sir. I also welcome today's moderators, Dr. Ashish Mehta from Ahmedabad and Dr. Venkata Ramarao from Vijayawada. They both are senior leading neonatologists in the country. Welcoming both of you to today's session, and I welcome all the delegates from all the 65 countries, and I wish you a wonderful session ahead. Thank you. Over to the moderators.
Yeah, Ashish sir, it's your turn.
Yeah, respected Professor Manuel, Professor VC Manoj, my co-host Dr. Ram, all office bearer of Kerala NF, friends and colleagues. Good evening. We know that Kerala NF started a webinar as a learning from legends. This is a series of webinars mainly as a part of the curtain raiser for NeoCon 2021. We had some fantastic webinars so far, and today also is going to be one of those. Volume ventilation in form of volume limit, volume guarantee has been added to conventional ventilation in recent past, and we have seen the good number of the research being done on the containing this volume trauma which is happening because of conventional ventilation. We also know that high frequency ventilation helps in opening up the stiff lung or very badly diseased lung. Now tagging this volume guarantee or volume limit to high frequency is really very interesting. And to give insight on this topic, we have none other than Professor Manuel with us to this evening. Friends, I'm sure at the end of this webinar, we'll be enlightened with we will be enlightened with the knowledge on volume and high frequency. May I request my colleague Dr. Rao to introduce today's faculty, Professor Manuel, please.
Hi, and good evening to all. Thanks for kind introduction, Dr. Madhusudan and Dr. Ashish Mehta. Good evening to all. Thanks to NNF office bearers of Kerala and IAP Neocon 2021 team, in particular, Sir Manuel sir. It's my honor and great pleasure to introduce Prof. Manuel Sánchez Luna from Spain. He doesn't need any introduction. He's a globally renowned speaker. He's a medical director of Neonatology Division and NICU. He's a professor of pediatrics at Hospital General Universitario Gregorio Marañón. That is a level 3C academic center associated to Complutense University, belongs to National Health System Madrid in Spain. He did his PhD and MD in pediatrics. He's full-time professor at National University Hospital since 1989. Prof. Luna was invited as a short-term scholar at the Colorado University, Denver in 2005. Prof. Also invited as professor at the Toronto University, Toronto in 2013. His area of interest are BPD, respiratory physiology, sepsis, shock, and personalized nutrition. Prof. Sánchez Luna was speaker and chairperson in number of national and international conferences and workshops of more than 250. He had so many publications in national and international scientific journals and books of more than 200. Prof. Also the president of the Spanish National Society of Neonatology from October 2019. He was ex-president of the Union of European Neonatal and Perinatal Societies, and also ex-president of International Neonatology Association. He was also ex-vice president of the World Association of Perinatal Medicine. Prof. Luna also did MBA in medical governance and hospital administration, and is a regular fellow of International Academy of Perinatal Medicine. He's also international advisor for neonatal nutrition, so group of growth and anthropometric neonatal study, the Intergroup 21 WHO anthropometry group. Prof. also advisor at the WHO program Small and Sick Babies and Every Newborn Results Framework 2020 to 2022. Yeah, I think with this brief introduction, I would like to hand over to Prof. Manuel Sánchez Luna for his valuable talk. So thank you all. Before that, please put your questions in question and answer box, please, not in chat box. Thank you all. Over to Prof. Sánchez Luna.
Well, thank you very much for this very kind and very nice introduction. For me, it's an honor and pleasure to be with all of you and to participate with these webinars and conferences along these 2 years. So thank you very much for inviting to me. And again, it's a great pleasure to share with you a few minutes talking about high frequency ventilation combined with the volume guarantee modality. So before going further, I would like to remember how the high frequency ventilation strategy is a very old strategy that we have been using in neonatology for more than 30 years. And the philosophy of the high frequency ventilation is to keep the lung stopped with enough volume of gas to produce oxygenation, and then given the use of this delta P, produce enough movement of the molecules inside the lung with a small delta P transmitted into the lung to produce very small tidal volumes, lower than the dead space. So with this philosophy, what we try to do is to keep the lung stable, stop, and preventing the lung injury of the conventional ventilation, and to be very effective in washing CO2. Most of the studies comparing the use of high frequency ventilation from many years to conventional ventilation in very immature babies using from the beginning after delivery didn't demonstrate any clear benefits of the use of high frequency. But when you review those studies, most of the studies were using different devices. Some of them were producing very large tidal volumes. And we know that the use of large tidal volumes, even on high frequency ventilation, can produce lung damage. Today, the technology has improved, and now we have the possibility to control much better the tidal volume and prevent what we call the large variability of this tidal volume during ventilation. So because we know that the tidal volume is related to the trauma on the lung and is very variable, and on high frequency ventilation, the tidal volume depends on the frequency, delta P, compliance of the respiratory system, the position of the endotracheal tube, or the presence of secretions. This tidal volume could be very, very variable, and sometimes going to be low, sometimes going to be too large. So we have the evidence from conventional ventilation combined with the volume guarantee modality that this modality of ventilation is much better than just pressure control. And the evidence behind is enough to demonstrate that the use of this kind of ventilation is going to decrease the risk of death or BPD, pneumothorax, mechanical ventilation, hypocardia, and severe intraventricular hemorrhage. So with this philosophy in mind, there was a possibility of combine this philosophy of controlling the tidal volume, not only for conventional ventilation, but during high frequency ventilation. So all of the studies I'm going to show you from now are studies done with the Dräger ventilator VM500, who was the one who was able to control tidal volume, just modifying delta P. How does it work? Well, you set any kind of tidal volume, then the ventilator is going to modify the amplitude just to set continuously exactly the tidal volume that you have been setting. By this, then for the very first time, you will be able to control directly this tidal volume. But it is very important that also combined with this philosophy, the software must prevent the excess of the leakage around the tubing that used to be happening during ventilation. In this graphic, you can see how when you are setting 10 ml of volume in this kind of situation to reach 8, you have to increase to prevent this 2 ml during inspiration of leakage. But also during expiration, there is another leakage of any kind of tidal volume. So at the end, if the ventilator really is setting 10 and is returning 7, most of the ventilators are going to increase a lot this tidal volume. And if you're trying to set just 8 into the lungs, then you're going to have a trauma. So the software compensation is extremely important to prevent this large variability in the tidal volume. And this is why probably this device is working so well with the volume guarantee modality. Without this software, we don't have enough information that this volume guarantee modality is going to work. So in these graphics, you can see how the tidal volume modifies with the frequency of the ventilator. This is the standard high-frequency ventilator. VtHf means standard high frequency. And then for many years, you have been seeing that anytime you increase the frequency, in this case from 5 until 15, there is a drop of the tidal volume. So for many years, anytime you wanted to decrease the PCO2 of your babies, you should have to decrease the frequency, just because it's the only way to increase the tidal volume. Also, you can increase delta P, but most of the time you were modifying the frequency to modify the tidal volume. Today, with these new devices and the possibility of controlling the tidal volume, now, as you can see, anytime you modify the frequency, there is no change in the volume. So for the very first time with these devices, if you want to clearly decrease PCO2 with the tidal volume continuously set and fixed, then you can increase the frequency, because then you are going to modify the CO2 WhatsApp. So with this philosophy in mind, in 2013, we began to do some experiments to go deeper in this kind of philosophy to know much better how it works in our babies. So at the beginning, all the studies were done in newborn piglets around 2 days of age, around 2.7 kilograms body weight. We analyzed the effect of this kind of ventilation during the normal lung situation, and after decreases the compliance because of bronchoalveolar lavage, taking out the surfactant of the animal. So in these two situations, we analyzed the effect of this ventilator. This was the very first study published around high frequency ventilation combined with the volume guarantee modality, and you can see this is the PCO2, and these are the tidal volume, and before and after the bronchoalveolar lavage, this is the normal compliance situation, this is the low compliance situation. And as you can see how anytime we increase the tidal volume, there is a direct decrease in the PCO2. So for the very first time, you can select directly and set directly tidal volume to modify the PCO2 of your patient. But the important thing is anytime you modify the compliance and you set the tidal volume at 3, for example, in this case, you can see how before and after the PCO2 remains stable. What was the ventilator doing? The ventilator was modifying delta P in all the animals to set exactly 3 ml per kilogram of body weight before and after. And in all the animals, the PCO2 was kept exactly the same. So this is the way this kind of ventilators are working so far. So 1 year after, and during the time I was visiting and working in Toronto, we developed a pulmonary testing set combined with CO2 instillation into this artificial lung. And we wanted to know the efficacy of this kind of ventilation, analyzing the CO2 WhatsApp with a computer software. Also, we wanted to test how the tidal volume was affecting delta P in 3 different areas: before the endotracheal tube, at the tubing, and inside the lung, because we wanted to know if this delta P was transmitted into the lung of the babies. So with this kind of design, we did these studies and we compare with and without the volume guarantee modality. The open bulbs are without and the dark are with, and you can see this is the tidal volume and this is the frequency. And again, you can see how without the volume guarantee, anytime you increase the frequency, there is a decrease in the tidal volume. But now with the volume guarantee modality, you can see how tidal volume do not modify, even if you increase the frequency as high as 15. This CO2 represents the ability of the high frequency to produce lavage of CO2. So you know that this CO2 formula comes from the square of the tidal volume multiplied by the frequency in hertz. So the higher this CO2, the more efficacy is the ventilator to decrease the PCO2 of the patient. Now you can see how anytime you increase the frequency without the volume guarantee modality, there is a drop in the DCO2. You have less effect on CO2 washout. Now, with this new modality, with the volume guarantee on, you can see how anytime you increase the frequency, there is an increase in DCO2 as well. So you can wash more CO2 from the patient, just increasing the frequency. So this was the first evidence. And now what was happening with delta P? So this is in white color, the proximal, in green, the endotracheal tube, and in this purple pink color, inside the lung at 5, 10, or 20 hertz. So you can see, so anytime how the frequency was increased, delta P at the proximal point increases. This is the white pressure. But inside the lung, there is no decrease or no increase. So the pressure is not transmitted. When you increase the frequency, it's not transmitted into the lung. And this is important because we know that even with a large increase in delta P, this pressure is not going to damage the lung of the baby. So you can see in graphic how this pressure in the blue color represents the proximal with the frequency increasing, and this is the volume guarantee on modality, how as you increase the frequency, there is an increase in delta P proximal to the endotracheal tube. But the inside pressure, inside of the lung, do not increase. Without the volume guarantee modality, look at this. What was happening before the use of this modality? So anytime you increase the frequency, there is a drop in delta P. And also there is a drop inside the lung. And this is why many times when you were using these all ventilators on high frequency, you choose normally a fixed frequency, but not higher than 10 or 12, because if you go further, then there's going to be a drop in delta P inside the lung, and probably the lung is going to be not well transmitted the pressure, and is not going to ventilate the baby's lung very well. Also, we wanted to test what was the effect of modifying the I/E ratio during high frequency ventilation. So most of the ventilator can modify, this is a graphic of 1:2, inspiratory time is half of the expiratory time, or 1:1, equal time for inspiration or expiration during high frequency with the volume guarantee modality. Before and after the bronchoalveolar lavage, we were doing these studies 4 years ago, and we demonstrated that without the volume guarantee, with the standard high frequency ventilator, the rate 1:1 was more efficient in decreasing the PCO2 at any frequency. And why is that? Because when you were using 1:1, tidal volume was higher compared to 1:2. So this is the reason why in all ventilators with high frequency without the volume guarantee modality, you want to wash out more CO2. Then the ratio should be 1:1 instead of 1:2. Before and after the bronchoalveolar lavage, this is the same without the volume guarantee, without the volume guarantee modality. What was happening now with the volume guarantee modality? Look at this. Because the tidal volume is fixed now, anytime you increase the frequency, there is a drop in the PCO2 using 1:1 or 1:2. But now the 1:2 is more efficiency in terms of decreasing the PCO2 before or after the bronchoalveolar lavage. So this is why we recommend with the use of volume guarantee modality to use 1:2 until you reach very high frequencies. Then you have to switch to 1:1 because if not, it's not going to have the ventilator enough time to set the tidal volume. So after these studies, we begin to think about the possibility of using a very low tidal volume to decrease the risk of lung damage. And to compensate the risk of hypoventilation, increases the frequency to compensate this decrease in the tidal volume. So with these leak compensation algorithms, we began to test this hypothesis, because if we demonstrate that the use of very low tidal volume is possible in our babies, then we are going to probably demonstrate that it's going to reduce the risk of ventilator-induced trauma. So before going further, we wanted to remember to all of you that during high-frequency ventilation, it's extremely important to have your lung recruit. How can you really know that your lung is well recruited? With the tidal volume control, with the volume guarantee modality, we high-priced some months ago that the possibility to better control if the lung is very well recruited is going to be possible if you look at the change in delta P. So we did this experiment that has been published just a few weeks ago in pediatric pulmonology in two different kind of experiments. One using rats' lungs, and we were connecting the rat lungs to different pressures of the high frequency, and we analyzed delta P just with the volume guarantee modality, looking after the change in delta P. So you can see how at 5, 14, 26, or 33, there is an increase in the lung volume, and there is a recruitment of the lung. And in between 14 and 26, the lung is well recruited. So you increase too much the pressure, your lung is going to be over-distended. But if you are below this pressure, the lung is going to be atelectatic. So how to really know if you are doing well? Well, we analyze the effect of the tidal volume of the delta P with the fixed tidal volume, and you can see anytime you increase the pressure, there is a drop in delta P until certain minimal pressure that it was around 18. Between 14 and 18, you have a very nice drop, and then there is no change in delta P. So this is giving to you the idea that if you follow delta P during the recruitment maneuver in your babies, if you look at this delta P, you're going to know very well if the baby is doing well. With the animal, we analyze the effect of this recruitment maneuver in PO2 as well, in the oxygenation. And you can see again, anytime you increase the minimal pressure, there is a drop in delta P, and at the same time, there is an increase in the oxygenation. So after certain minimal pressure, there is no change in delta P, and there's no any change or any increase in the PaO2, demonstrated that you can follow very well the recruitment of the lung just looking at delta P. So going back to the hypothesis of the risk of tidal volume to produce ventilator-induced trauma in our very immature babies, we began to test the possibility of using this modality with very low tidal volumes in babies. So in this study that we published 4 years ago, we just wanted to test the possibility of using this modality, and if this was well tolerated in our preemie babies. So in babies of less than 32 weeks gestation, even less than 1,000 grams, what we did, we stabilized the babies on high frequency, and then we tried to switch from the regular tidal volume to the lower tidal volume as possible, and compensate this CO2 increase in the frequency. So you can see how in our babies, we decrease from 2.2 to 1.6, a great decrease in the tidal volume. These are ml per kilogram of body weight. And you can see how this CO2 was similar, even lower. The babies were doing very well. And we increased the frequency from 10 to close to 17. So we demonstrated that this modality can be used in very immature babies. And even more, anytime you modify the tidal volume, you decrease the tidal volume, increasing the frequency, babies were having exactly very similar PCO2 before and after. So this kind of modality can be used. But we wanted to test really if this modality is going to really prevent damage into the lung. So what we did is a very long study. This study was published less than 1 year ago, and comparing animals, newborn animals, the different effect of using standard 10 Hertz with a standard tidal volume versus very high frequency 10-20 with a very low tidal volume during 12 hours of high frequency ventilation in a very low compliance lung after damage. So here you have the results. These are the lungs from electronic microscopy of the group of the animals that were ventilated for 12 hours with 10 Hertz and regular tidal volume. You can see how the lungs, the cell, the alveolar area is destroyed. You have a lot of necrosis of the nucleus of the alveolus. But if you look at the lung of the animals that were ventilated for 12 hours with 20 Hertz and very low tidal volumes, these lungs appears very normal. And if you look at the standard histology, the group of the animals with 10 Hertz during 12 hours and normal tidal volumes, you can see how the lungs are destroyed. You have a lot of necrosis, you have a lot of rupture of the areas, and you have a lot of inflammation. But looking at the lungs of the animals of the 20 Hertz situation during 12 hours and very low tidal volumes, you can see how the lungs appears very normal. So if you apply what we call a lung damage score, and we compare even with the conventional ventilation, the animals in the group of 20 Hertz, they demonstrate to have a very less damage score compared to the conventional ventilation or the 10 Hertz during 12 hours of ventilation. Also, we wanted to test the gene expression after these 12 hours ventilation in two groups, and compared to the 10 Hertz, those cytokines that increases the protection of the lung are overexpressed, and those cytokines that produce lesion, produce inflammation into the lung are decreased. So in these experiments, we demonstrated that probably the use of very low tidal volumes is going to protect the lung of the very immature babies. So in summary, with this modality of high frequency combined with the volume guarantee, we can fix the tidal volume and we can modify directly the tidal volume to induce lung damage, to induce PCO2 washout. And probably using very low tidal volume in very immature babies and maintaining the PCO2 normal with very high frequencies, we can probably protect the lung of the ventilator-induced trauma. So this is in summary what I wanted to talk and to review with you. Of course, this is a very new modality. We need to test in large studies in our preemie babies. We are going to publish probably next the results of our population of babies, premature babies, with the use of this high frequency ventilation. Until now, the experience is that those babies with this philosophy, very immature babies with very low tidal volume, are doing much better than before with the standard high frequency ventilation. So thank you very much for your attention. And now I'm very open for you to answer your questions or your comments. Thank you.
Ashish sir.
Yeah, thanks for the very lucid presentation, Prof. We have a few interesting questions here. First of all, can I start ball rolling? Normally, with high frequency without volume guarantee, by increasing frequency, you expect increase in the CO2, which is exactly opposite to conventional ventilation. Now with HFE plus VG, it is exactly like conventional. By increasing frequency, there is washout of the CO2. Am I right?
Yes, you are very right. This is the main difference. So
And why this happens?
during the standard high frequency, anytime you increase the frequency, you have less time to send the tidal volume. So then the tidal volume decreases. So because you decrease the tidal volume and the dCO2 efficacy formula to wash out the CO2 depends on the square of the tidal volume, any change on the tidal volume during high frequency will produce a tremendous change in the pCO2. So with the standard high frequency ventilator, anytime you increase the frequency, you have a shorter time and less tidal volume is going to be sent to the lungs of the baby. Today, with the volume guarantee modality, you fix the tidal volume. So the frequency do not have any effect on the tidal volume. So the tidal volume is constant. So dCO2 now depends only on the frequency of the ventilator, not on the tidal volume, because the tidal is fixed. This is why now with the volume guarantee modality, if you increase the frequency, as you are using in the conventional ventilation, you will decrease the pCO2 of the baby.
Great. Now there's a question about when using volume guarantee with HFO, someone realized that VtHf 2 ml per kg, the amplitude is usually quite low. There is sudden drop in the amplitude, which is something like 1 1/2 of the mean. Is it normal phenomena?
So can you please repeat the question when you...
Yeah, what she says that by putting the VG of 2 ml per kg, normally with HFV we expect volume guarantee of 2 ml per kg. Now when you set the VG of 2 ml per kg, there is sudden drop in the amplitude.
Well, the drop in the amplitude is because we modify mean airway pressure, and then we recruit the lung. So when the lung is collapsed or is over-distended, delta P is not well transmitted into the lung. So anytime you open the lung and you produce a nice functional residual capacity, then delta P is very well transmitted. So at the beginning, anytime you increase and increase and increase the lung volume, delta P begins to drop until your lung is well recruited. Then any further increase in mean airway pressure is going to produce no further decrease in delta P. So the lung is going to be over-distended, but the transmission of the pressure is going to be the same or even less.
Okay, great. Now, what is the lowest tidal volume and what is the highest frequency that one can use?
Well, I must remember that this philosophy we wanted to apply in very immature babies during the first few days after delivery with a very severe respiratory distress syndrome. So normally in bigger babies with a meconium aspiration or bronchopneumonia or whatever kind of diseases, this philosophy do not represent a clear advantages because you are going to use higher tidal volumes. But the problem with the very immature babies is that you have to use the lower tidal volume as possible. So at the beginning, when we began to use this technology around 2014, we began to use around 1.5 ml per kilogram of body weight of the immature babies. But now, when you set this tidal volume, if you can decrease as much as possible the tidal volume, you're going to go down to 0.6, 0.7, or 0.8 ml per kilogram of body weight. So to compensate this CO2, you have to increase the frequency. So the higher frequency normally is around 18 to 20 hertz. 20 hertz is the maximum frequency that we have been using in our preemie babies.
Prof, now conventionally without volume guarantee HFP, for big babies like meconium aspirations or PPHN or diaphragms, you try to ventilate them with the 6 or 8 hertz. And in small babies with HMD, you try to keep it 12 to 14 hertz. Now with this volume guarantee, which kind of frequency would you like to select for different diseases?
Again, we try to use the higher as possible, but you have to remember, because many times many people are asking me for advice to ventilate those babies. And sometimes we have to use very high tidal volumes, not only because the baby is bigger, but also because the physiological dead space is bigger. So normally the dead space anatomic is around 2.7 ml per kilogram of body weight. What is the problem? Well, the problem is sometimes the lung is so damaged and you have a shunt right to left, so big that the ventilation is not very efficient during ventilation in these kind of babies. So you have to increase sometimes even over the dead space, and you have to go close to 3 ml per kilogram of body weight. So this is a lot, of course, but sometimes it's represented that the damage on the lung is very high, or you have a very high dead space of those babies. So those big babies, sometimes they go around 2, 2.3, 2.1, 2.5, and to reach that tidal volume, we normally go to the highest frequency as possible. This is the way we used to use in these kind of babies. Sometimes this is around 6, sometimes this is around 12. Depends on the mechanics of the lung that you are ventilating.
But like in a bigger babies, you try to keep the small frequency, and smaller baby try to keep high frequency conventionally. That doesn't apply over here. Am I right?
Yes, you are right, of course. So the bigger the baby, the less effective is the high frequency, because to be transmitted the pressure delta P, you need to have a very small lung with very short bronchus. But in very big babies, around 3 or 4 kilograms of body weight, then the lung is bigger and the bronchi are very well branched. So the transmission of the pressure is very low. This is why in studies in adults and bigger babies, high frequency really doesn't work. So in neonatology, we're very fortunate because we can use high frequency very well, because our babies, they do have a very small lung with very short bronchi. So the transmission of the delta P and the creation of enough tidal volume is very easy to be done. Also, you have to remember that during high frequency with a low compliance, the delta P is very well transmitted to anywhere of the lung. But if you have a very high resistance with the closing of the bronchial diameter, then the transmission of the pressure is very bad. So this is why many times during very severe meconic aspiration or babies with bronchiolitis, high frequency doesn't work. This is because the obstruction, the high resistance of the lung is not producing enough effective delta P transmitted into the lung. So you have to remember, many times some people are asking, oh, the high frequency is not good for bigger babies, so we don't want to use. Okay, be careful. We have to be very clearly what is high frequency and what is the best indication. So the smaller the baby, the lower the compliance, the more efficacy is the high frequency ventilation. The bigger the baby, the higher the resistance, the less efficacy of the high frequency ventilation, with or without the volume guarantee modality.
Great. Dr. Kishore would like to understand. Can you re-explain the way you increase the delta P? Can you explore something again about that?
Well, I'm going to share again that slide. And going back, well, the idea is that when we are recruiting the lung, when the lung is collapsed, the transmission of delta P is very well until you have enough volume into the lung. So when the lung is overdistended, is well recruited, any further increase in the mean airway pressure is not going to produce a further decrease of delta P. So we found in these are lungs of rats around 160 grams that from normally around 14 to 16, then any further increase in mean outward pressure is not going to produce further decrease in delta P. So if you look at the animals and look at the oxygenation, when you increase mean outward pressure and you recruit the lung, you have a very nice increase in the PO2 until certain number. Why? This is because you reach the overdistension of the lung. And it is well reflects the oxygenation in delta P chains. Look, when you are increasing the mean outward pressure, you have a very nice drop in delta P and very nice increase in oxygenation. After a certain mean outward pressure, there is no further drop in delta P, there is no further increase in PO2. So anytime you connect a baby to high frequency ventilation first, before thinking about tidal volume, what you have to do is to recruit the lung of the baby. To work, to work with the nice, functional residual capacity, and then increase the possibility of produce a very good oxygenation, a very good wash out of CO2. If your lung is not well recruited, then the high frequency is not going to work even if you're using any kind of delta P. So this is how it works.
Ram?
Yeah, I'm here. So, first of all, thanks to Prof for your excellent and very informative talk. So, I have a few questions for you from the participants. So one of the participants had asked, how do you decide at the bedside what is the ideal tidal volume to set for a baby at a given frequency?
Well, what we used to do is to, at the beginning, depend on the weight of the baby, we set a standard tidal volume. This should be around 1 in babies of less than 1,500 grams, or around 1.5 to 2 in babies close to 2,000 grams. Then we set the frequency to produce the normal PCO2. Then what we try to do is to decrease the tidal volume as much as possible and increase the frequency to keep same DCO2. Then you are going to find the highest frequency where no more frequency can be reached without a decrease in the tidal volume. That is the higher frequency and the lower tidal volume that you can use. So the important thing is to remember that every single baby, every single mechanics of the lung situation will need a specific tidal volume. So what we try to do is to stabilize the baby in the lowest tidal volume as possible. And this normally in babies less than 1,000 grams is less than 1 ml per kilogram of body weight, around 0.7 or even 0.6. So you can do that, then probably you're going to decrease the risk of ventilator-induced trauma.
Okay, and the second question, Prof, in HFOV with the volume guarantee, is the flow variable? If not, how is the fixed flow dissipated? So one of the participants asked this question.
Do you mind to repeat the question again, please?
HFOV with the volume guarantee is the flow variable. Flow variable.
It is not flow variable. It's pressure limited ventilation. So the flow doesn't change. So the flow is adapted from the ventilator to reach exactly what tidal volume you need. But the important thing is that the flow is standard. What you do is to modify delta P, just to produce the set tidal volume, okay? So the variability of the flow is the same as without volume guarantee. So flow goes in, flow goes out, because this is an oscillator. So the flow just move in and out all the time at very high frequency and produce delta P and produce tidal volume. These are the three standard settings of any high frequency ventilator.
Another question for you, Prof. Can you explain more how increasing the frequency results in drop in the delta P in HFOV without volume guarantee?
Now, without volume guarantee, you're blind. I'm so sorry. So this is one of the problems. So without the volume guarantee, and without knowing how much tidal volume you are sending to the lung of your baby, oh my God, this is extremely difficult, probably unsafe.
Mm-hmm. And another question, Prof. How small tidal volume during high frequency do you advise? And do we need to maintain a constant DCO2?
Well, the lowest as possible again. So again, every single baby, every single lung situation is going to have a single tidal volume and a single DCO2. So what we try to do is to analyze what is the best tidal volume and DCO2 in a standard situation. Then we try to keep and maintain that tidal volume, that DCO2 in the rest of the hours. But remember that the lung condition is dynamic. And many times the baby's lung is going to decrease or even increase compliance, decrease or even increase resistance. So tidal volume is going to be fixed, but delta P is going to modify. So one of the important things is that if you know and you can see that the delta P is decreasing, then probably the situation of the lung is improving. Very similar to conventional ventilation with the volume guarantee modality.
Prof, how do you set the inspiration expiration ratio while increasing frequency?
So as I showed you, in the slides, without the volume guarantee, the ratio 1:1, so having more inspiratory time is going to be more effective in CO2 assault. With the volume guarantee modality, the ratio 1:2 is more efficacy because you have tidal volume fixed and you have more time for expiration. So probably you're going to decrease the risk of gas trapping. So until you reach a frequency of 15 in our institution, we try to keep 1:2 ratio. Then after 15, we increase to 1:1, because if not, the ventilator is not going enough time, is not going to have enough time to set the tidal volume.
Prof, will this modality HFOV with the volume guarantee help in babies with chronic lung disease?
Well, this is a very good questions. The problem with the bronchopulmonary dysplasia is that those lungs normally they do have a very variable compliance and a very variable resistance. So high frequency many times doesn't work in this very chronic lung disease if the compliance is normal and the resistance is very high. So only in those situations where the compliance is low and resistance is low, or compliance is not very high, then the high frequency can work. But in those babies, normally we switch to conventional ventilation and we put the babies on PSB plus volume guarantee to keep the lungs in a more comfortable way of ventilation. So we recommend the high frequency normally during the first few days in the very severe respiratory distress syndrome of very mature babies. But in chronic disease, we many times do prefer the use of conventional ventilation. And the combination of PSB plus volume guarantee for us is the more physiological and convenience ventilation mode.
Yeah, but does it help in decreasing BPD? Do we have any trials? We showed a few beautiful slides where the lung architecture is preserved with higher frequencies, 10 versus 20. But do we have any paper or do we have any research whether there's a decrease in the BPD with HFOV+VG?
Well, yes, we published 2 papers, 2 studies that we demonstrated in the pre and post use of high frequency. We decreased the number of babies with grade 2 and 3 BPD, not the full number of babies with BPD. As you know, mild BPD or grade 1 is a condition more related to the immaturity of the babies, but grade 2 and 3, moderate to severe disease, we found a decrease, clear decrease in our babies with this modality of high frequency ventilation.
Prof, this is actually my question from my side. We've been using oscillation for more than 30 years or so. And then certainly I've been using oscillation for the past 25 years, Prof. I've started using oscillation when I was in the UK, in the Liverpool, Women's Hospital, Liverpool, with Prof. Cook. So the question to you is, even though we have used for more than 25, 30 years, still, studies have shown that, there wasn't any kind of added advantage. Equal number of studies have shown that there wasn't any added advantage when compared to conventional ventilation. Still, we've been using for 20, 25, 30 years. Why is that, sir? Can you comment on that, Prof?
Well, I must, as you are talking about UK, I must remember the study published by the UK group of comparing high frequency to conventional ventilation. That study was published in 2002 in the New England Journal of Medicine, and they didn't demonstrate any benefits of using high frequency compared to conventional ventilation. But if you go deeper to the paper, to the study that you did, those hospitals that were using a ventilator with larger tidal volumes, not analyze or measure tidal volume as the sensor medics, they did have worse results compared to those babies who were ventilated with a flow sensor connected ventilator as the Dräger. Number one. Number two, as you know, close to 17 years after, the investigators look at those babies in the follow-up and they analyze the pulmonary function test. And they demonstrated a statistically significant benefits in terms of better pulmonary function test. In the babies, after those years, were ventilated on high frequency compared to conventional ventilation. So the hypothesis is probably that many of the babies who were in the beginning of the study were being ventilated with very traumatic ventilators, not controlling the tidal volume, and probably inducing ventilator damage. There is another trial published at the same year by Corney and collaborators in the United States. In that study, they use higher frequencies, that's in the UK trial, more than 10 hertz. And they were using very small tidal volumes, probably because they were using higher frequencies. In that study, they did demonstrate the benefits of using high frequency compared to conventional ventilation. I'm telling you, about 18 years ago. Today, with the new technology that we can control much better the tidal volume, probably we should have to repeat that study to better analyze the difference between using a very low tidal volume on a high frequency compared to conventional ventilation. This is what I can tell you now.
Thanks, Prof. Over to Ashish, sir.
typically when you want to set a baby on the HFOV+VG, the first thing that you go is to set the VG first. And as you already mentioned that smaller the baby, try to keep small volume. Then adjust the frequency to adjust your DCO2. And then looking at the FI to adjust your delta P. Am I right?
Yes, you're right. But in the volume guarantee, what we try to do is to put or use the higher delta P, because delta P is not going to be transmitted into the lung, as I told you. So anytime you increase the frequency and you decrease the tidal volume, the ventilator is going to adapt delta P nicely. So forget about delta P. Just keep the tidal volume in the lowest figure as possible and frequency in the higher figure as possible. And put delta P in a high number. Normally, in very mature babies, delta P is not higher than 17 or 20. This is the higher normally that we used to use.
In small baby also?
In very small babies.
But
yes.
Will it not affect the hemodynamics then?
Excuse me?
Will it not affect the hemodynamics? Like
What?
Pressures, cardiac output or mean blood pressures? Or
well, normally the pressure what is going to produce damage into the baby's lung or circulation of the heart is not delta P, it's mean airway pressure.
Okay.
And this is a different setting. So you have to set mean airway pressure to recruit the lung and to produce functional residual capacity, and then delta P to produce tidal volume. So these two different pressures, you must be balanced. And this is how we pay a lot of attention when we recruit the lung of a baby. And this is why we did these studies that we have published just 1 week ago to better analyze, to use, again, the lower mean airway pressure as possible to prevent what you were telling me, to prevent the damage in the cardiocirculatory effect. So you need to have regular volume into the lung, but no overdistension of the lung.
So try to keep mean air pressure at minimum and try to keep delta P to the higher side.
Yes, of course. So minimal mean airway pressure, but with the lung recruited.
Okay.
So when you recruit the lung, what we do normally is to increase step by step mean airway pressure until we find what we call the oxygenation increase. Then that number is the opening pressure or critical opening pressure. What we did then is to decrease FiO2 until normal oxygen saturation, and then we decrease again back mean airway pressure before the oxygenation decreases again. And then we increase 2 centimeters of water.
Great.
Over the what we call the closing pressure of the lung. So we used to check every single day, because the pressures to keep the lung open modifies along the ventilation of the baby. So at the beginning, the compliance is very low, or the situation of the lung is very badly, probably you will need more mean airway pressure than the day after. So it's important, because sometimes and this is the same in conventional ventilation, sometimes today you need more pressure than tomorrow, but if you don't modify the pressure, then the baby's circulation is going to be damaged by the ventilator. So you can't leave alone the baby with the ventilator. You have to check every day mean airway pressure and delta P. But delta P is going to inform to you how the lung is. And this is extremely important, because you can reduce also X-rays. Now we have another tool, very important tool that probably we will test, because some of our coworkers are very good expertise in lung ultrasound, and probably they are going to give us in some time very nice data about if the baby's lung is well recruited or not, looking at the ultrasound of the lung. So
very interesting.
But you have to check every single day.
Now, at what stage will you think of winning and how do you win from this settings?
Well,
this
the
particular-
winning normally is automatic, because this is a very good question, because when the compliance increases because the baby improves, normally the baby on high frequency ventilation begin to increase PCO2, because you have to remember that during high frequency ventilation, the transmission of delta P is much better with a very low compliance. So when the baby improves, one of the signal that you have is that the PCO2 increases slightly. And the other thing, you need less FiO2. And the other one, delta P decreases to produce the same tidal volume. So this is the time normally with an FiO2 lower than 30 and a mean airway pressure in preemie babies lower than 7 or close to 7, to wean the baby from the ventilator or wean the baby from the high frequency. This is up to you.
Okay, great. So you don't wean on the volume, just wean on the pressures on FiO2.
Yes, of course, because the tidal volume is fixed. So you will see that to get the same tidal volume, delta P is going to be less and less. And FiO2 decreases, and probably the PCO2 will increase a little bit. So this is the time to decrease mean airway pressure and wean the baby from the ventilator.
Now we understand that all your studies are on VN 500. People around, they may not be lucky enough to get VN 500 all the time. So which other ventilators can serve the purpose of HFV with VG?
Well, for more than 30 years, I've been working with the Dräger company. All of the ventilators that we have been using are Dräger. So I don't have any experience with other kind of ventilators. But again, you have to be very careful with the leak compensation software. So if you don't have this leak compensation possibility, then the risk of not controlling very well the tidal volume is very, very, very high. Okay. So I can't recommend to you any kind of ventilator, but the one you are going to use, please be sure that you have this leak compensation.
Okay. But does this mean that we traumatize so many babies' lung without VG, only on high frequency, using high pressures and high tidal volumes and all that? So far, that is what we have been doing.
Well, it is much better to use a device that you know very well and you produce very low trauma than the new one that you are not controlling. Anytime that you're going to produce a lot of trauma. So be careful with new devices not well tested in babies or in animal studies, because the risk of producing damage is much higher than using your old standard conventional ventilator devices.
Ram?
Yes. Thank you. Yeah. Prof, do you still have some time to answer questions, Prof?
Yes.
Okay, thank you. Prof, no, the another question from the participant was higher frequency, does it affect cerebral hemodynamics?
Higher frequency? The question is higher frequency?
Does that one affect cerebral hemodynamics?
Not at all. Not at all. You know, the hemodynamic is mostly affected by the mean airway pressure, but not by the frequency or delta P. Delta P is not transmitter, and the tidal volume is below the dead space. So this is why I'm recommending to you to check every day the mean airway pressure that your baby needs. You can decrease it without de-recruiting the lung, decrease the pressure. Yes, of course. But this is not delta P. This is mean airway pressure.
Prof, what is the maximum frequency that you can use in a smaller premise with the severe ODS?
The higher frequency, 20.
What's the max you could go up to?
20.
20, yeah.
20 in our devices. We hope that in the near future, we will have more powerful ventilator that could go up to 30 probably, because we found that the higher the frequency, the more efficacy of the high frequency ventilation to decrease PCO2. So it is safer to be in very high frequency than to be in very low frequencies.
Yes, Prof. Thank you. Prof, one of our beloved professors, Dr. K.K. Devakar sir asked, I think this has already been answered. Carbon dioxide blowing out with the increased frequencies and interesting information. This is a phenomenon with the volume guarantee Dräger specific ventilator, or can it be applied to all the high frequency ventilators? This has already been answered now, Prof.
Yeah.
The Prof, and the other one is, generally it is believed that the high frequency ventilation is a last resort. That means a kind of rescue mode in preterm babies. So from your study, do you postulate this should be preferred method compared to conventional ventilation? Because I was still remembering, during the years 95 to 97, when I was in the UK, we used as high frequency oscillation as the primary mode of ventilation in preterms, extreme preterm babies, and then after that we stopped using it. We used it for a couple of years or so because it wasn't showing any benefit when compared to conventional ventilation as a primary mode of ventilation. So, can you just comment on this, Prof?
So today, I think that the most important thing is to remember that, number one, try to do not intubate any baby if you can. So this is number one. Number two, apply nasal ventilation if you can, instead of intubate the baby. And if you can synchronize the baby with the respiratory effort, it should be much better. Number two, you have to intubate the baby. Today, still, we use as a primary invasive ventilation PSB plus volume guarantee in conventional modality. But anytime we find that the lung condition of the baby is very bad, or you need very high PIP to keep around 4 ml per kilogram of body weight, this should be more than 15 or 17 of PIP in extremely premature babies, then we switch very fast to high frequency. So high frequency for us is a rescue therapy. It's not the first primary mode of invasive ventilation. Today, because we don't have enough evidence, as you said, that this modality is better than conventional. But today, we have very low numbers of babies who need to be intubated. So in those babies, we switch very fast from conventional to high frequency if we look or we see that the FiO2 is high, or the PIP that you need to send 4 ml per kilogram of body weight or 5 ml per kilogram of body weight is very high. Then we switch to high frequency. So high frequency for us is a very early rescue therapy.
You mean to say 4 ml per kg of tidal volume to set that as a PIP?
Yes. Yes, unconventional ventilation during the first few hours after the beginning of the ventilation.
Another question is, when and how to wean off from this HFOV with volume guarantee? That is the first part of the question. And second part of the question is, could we directly extubate babies from HFOV with VZ? Or do we need to switch over to conventional ventilation and then wean and extubate, Prof?
Well, about the second question, yes, you can do. If the baby is on coughing, if the baby is breathing spontaneously, so one important thing is keep your baby without muscle paralysis, please, on high frequency, and keep your baby moving if you want. Or, for example, we do many times kangaroo care on high frequency ventilation with the volume guarantee modality. Why? Because the volume guarantee modality is going to control very well the tidal volume. So you can move the baby can breathe spontaneously over the high frequency ventilation without any problem. So if the baby is awake, if the respiratory center is well, if the coughing is given, you can wean the baby to nasal ventilation from high frequency without any kind of problem. Also, you can switch, because you have the same ventilator, you can switch very fine, very easy to conventional ventilation to check for a few hours before weaning the baby. Doesn't make any sense. The first question, do you mind to repeat to me?
It's a when and how to wean from HFOV with volume guarantee mode.
Well, the weaning is, as I told you, the baby is improving. Then the very first signal is you need less FiO2, and you can decrease mean airway pressure. Then, if the tidal volume is set, but delta P is decreasing, when we reach around 30% oxygen or a mean airway pressure around 7, very immature babies, probably between 5 and 7, we extubate the baby, or we switch to nasal ventilation or conventional ventilation. But the baby normally is automatically weaned from the ventilator with the volume guarantee modality.
Has it happened that you need to change to another mode if this fails? Does it fail? It looks very promising that you've got tidal volume control, and then the tidal volume adjusts the delta P, and it looks quite interesting. But does it happen that you need to change to another mode if this fails?
Well, life is very complicated, you know, and sometimes things are not so easy at the baby side. So some of the reason that the high frequency doesn't work is because you have a lung condition with a very normal compliance and very high resistance. So before thinking about strange things, if your baby is not going well with a high frequency, probably it's because your lung is not so sick. So normal compliance, high resistance doesn't work with a high frequency. This is the #1 problem. Sometimes you have a very low mean airway pressure. And if you have a very low mean airway pressure, your lung is atelostatic. But also you sometimes have too high mean airway pressure, and you have overdistension of the lung. So check your lung size. If you have to do an X-ray, and try to keep the lung with less than 9 spaces, or around 9, in between 8 and 9, no more than 10, of course. Because sometimes it doesn't work because you are using too high mean airway pressures. So these are the main clear situations. One of the standard problems that sometimes you have is when the babies improve very fast, then sometimes you go very fast to decrease mean airway pressure, and your lung decreases very fast as well, and you return to the previous condition. This is very, very typical. And the other thing is you increase too much the mean airway pressure, the baby improves, but you don't decrease again mean airway pressure, and the baby's lung improves, and you overdistend the lung. And these are the other typical situations why the high frequency doesn't work.
At times what we have seen that leak compensation is there, but does it work for all kind of leakages, or it for example 50% leakage it works well, 60% leak it works well? So up to what percentage of leak this leak compensation will work? Because at times you are seeing the baby's weather is fine, but 80-90% is leak, and the numbers are not to be believed when the leak is too high. If you
Well,
look at the babies,
there are some studies, one from the group of Colin Morley, we have been testing a lot, that with the VM500, up to even 80 or 90% of the leakage, the ventilator is going to compensate.
okay.
So no problem, it works.
It works. Okay, great.
Yeah.
Yep. Ram, anything?
I think from my side, we've nearly finished. I think so already 8:48. We had more than 45 minutes question and answer session. So I think it's better to give rest to Prof. Prof. Yeah.
Anyway, thanks a lot, sir. There is a great discussion here. We came to know about high frequency volume guarantee as a first webinar on HFOV+VG in this country, I must say that. and very interesting. Thank you very much for clear all concepts.
Yeah.
Well, thank you to all of you. And before leaving, please take care, be safe,
1 minute.
and take care of our preemie babies as well.
Sure. Over to Professor VC Manoj, please.
Yeah.
Am I audible?
Thanks a lot, sir. Yeah.
Am I audible?
Yep.
Thank you, Professor Manuel. In fact, this is the 4th talk of yours that I had the pleasure and the honor to listen to, and every talk of yours is so enlightening. For most of us, the concept of HFO+VG is so confusing, but for some of us who have dared to start using this, I must say it is a compelling mode. That's why I was keen to have this talk. Thank you, Professor, for joining us today. I must say, you are the legend, rather the pioneer researcher in this field of HFO+VG, right from the earlier animal studies of yours. Sir, we also hope to have you with us in Kerala for the IAP NeoCon next year in September 21, God willing. We humbly hope that you...
Manoj, we would like to do a workshop with him.
We will do that. We will plan.
Yep.
Now, before I request our NNF Kerala Secretary Dr. Vishnu Mohan to propose the official vote of thanks, may again thank all the delegates and invite all of you for the next webinar in our series on 27th of October. That's after another maybe a few more days, Tuesday, by Professor Lucky Jain from USA on a very contemporary topic, COVID-19 and you, the well-being and safety in this pandemic. Please do join us on 27th of this month as well. Thank you so much. Now over to Dr. Vishnu for the official vote of thanks.
Very good evening to all. On behalf of the organizing committee and the IAP Neo Chair, I thank our dear legendary speaker, Dr. Manuel Sánchez Luna, for that excellent and wonderful talk today. Thank you very much, sir. I also thank our moderators, Dr. Ashish Mehta and Dr. Ramarao, for moderating our session so wonderfully. Thank you, sirs. Last but not least, thank all our participants who are attending today's session on Zoom as well as on YouTube for being with us today. Thank you all. See you all on 24th again. Stay safe.
Stay safe. Thank you very much. Thank you, sir.
Thank you. Thanks to all. Thanks to Prof.
Thank you. Thank you very much.
Thanks, Manoj sir.
Thank you.